This is Dr. Michael Trainer. I have created this video to discuss lumbar decompression, instrumentation, and fusion surgery. This video was created to discuss risks, complications of the surgery, as well as describe to patients instructions prior to the surgery. With regard to the risks of lumbar surgery, specifically lumbar decompression with instrumentation and fusion, the first risk we discuss with patients is the risk of infection. Infection can occur anytime a cut is made in the skin. Infection is prevented by giving patients preoperative IV antibiotics. Those antibiotics are given at the time they come to the hospital and just before the incision is made. Patients will also receive IV antibiotics in the recovery room following their surgery. Patients do not require at-home antibiotics or antibiotics taken orally following the surgery. The lumbar surgery involves the lower back, which is the lumbar spine. Most of the lumbar surgeries are performed entirely from the back side of the patient's body. Occasionally, some surgeries will be performed through a side approach or through a front approach. If the surgery is performed through a front approach, that surgery is typically performed with a vascular surgeon who assists with the procedure. The reason the vascular surgeon assists with the procedure is because in order to access the lumbar spine, there are blood vessels that need to be moved during the surgery. Discussion regarding that type of procedure will be made with the patient at their preoperative visit if that is the particular surgery that the patient is going to undergo. Some patients will have the surgery from a side approach, and during that surgery there is also risk to nerves and blood vessels which are encountered through the front-sided approach. However, the side approach does not require a vascular surgeon. The vast majority of patients who undergo the lumbar surgery have the surgery performed through the backside. The spinal cord ends at the first lumbar vertebrae. There are 5 lumbar vertebrae, and therefore there is not typically significant risk to the spinal cord. However, there is risk to the lumbar nerves. The lumbar nerves come off the end of the spinal cord, and those nerves travel down the legs. So there is always a risk to the lumbar nerves during a lumbar surgery. We also discussed the risk of what's called a dural tear. The dura is the covering that houses the spinal nerves and even the spinal cord all the way up to the brain. The dura is a saran wrap-like tissue, so it's clear tissue, almost like a balloon, and it houses the cerebrospinal fluid and the lumbar nerves. During lumbar surgery, patients are at risk for what's called a dural tear. The reason it can be torn is if the nerves are compressed and we are trying to free the nerves. Sometimes disc fragments or other tissues will stick to the dura, and in removing those tissues, the dura could sustain a tear. If a tear occurs, we will see it because we will see cerebrospinal fluid start to leak. If that occurs, the tear needs to be repaired. It is typically repaired with sutures, but also we can use glue or patches to repair the tear. If a patient has a dural tear, it may slow the recovery because oftentimes patients are kept flat in bed for up to 24 hours after a dural tear. The reason being, when patients stand and walk, they also increase the cerebrospinal fluid pressure, which could compromise the dural tear repair. So again, if a patient sustains a dural tear during the surgery, it will be repaired, but it might slow down the recovery. If a patient sustains a dural tear and it does not seal, they may require additional surgery. A dural tear that does not seal can result in what's called cerebrospinal fluid leak headaches. These are the worst headaches that a patient could ever experience, and they will know it because the headaches are extreme and they are positional. What that means is the headaches will typically subside when they lay flat, but they will increase if they stand or walk or load their spine. Also, any increase in intra-abdominal pressure can increase headaches associated with a cerebral spinal fluid leak or dural tear. So for example, if a patient was straining to have a bowel movement following surgery and they had a dural tear, it might cause significant headaches. The other sign that a patient may have a dural tear with a persistence of cerebral spinal fluid leak would be if clear fluid is draining from their incision site. Other risks associated with the surgery include, again, nerve or vessel injury, worsening of symptoms. During the surgery, I do not fix the nerves, I just make sure they are no longer compressed. If the nerves are not permanently injured, then by decompressing the nerves, they should get better over time. That time frame may be very short, but for some patients, it can take up to 6 months to notice any significant nerve improvement. At 6 months, 90% of patients will have the best improvement that they will be able to achieve with surgery. There are about 10% of patients that might have nerve improvement that continues up until 1 year after the surgery. After that, typically whatever improvement was achieved with surgery will be present at that point, and any residual symptoms will likely not change. We explain this to patients because some patients will notice significant improvement right after surgery, but if they do not experience that improvement, it is not something to be alarmed by. It may take some time for the nerves to recover. The nerves recover typically by about 1 millimeter a day, and these nerves go from the lower back all the way to the toes. So this is why 6 months is a standard time frame to expect nerve recovery. Oftentimes during the surgery, precautions will be taken to avoid nerve injury. The typical precaution is what's called intraoperative nerve monitoring, meaning during the surgery, patient's nerve function is monitored with a special apparatus. Once the patient is off to sleep, the nerve monitoring technician is able to insert needle probes from the skull to the toes. The needle probes are attached to a monitoring system that allows a neurologist to monitor the function of the nerves during the surgery. In this way, we can protect the nerves throughout the procedure. Once the decompression portion of the surgery is performed, next comes the fusion portion of the surgery. The fusion involves typically removing the disc, which is the cushion between the vertebrae, and placing a spacer that will replace the disc. The spacer is filled with bone. The bone will heal one bone to the next. That is a fusion. By fusing the vertebrae in the correct position, the patient will not experience grinding and rubbing on the bad disc, and the bones will be separated to maintain the appropriate alignment of the vertebrae. This will also then ensure that the nerves that are housed in the spinal column will no longer be pinched. In order to stabilize the construct, typically screws and rods are placed in the vertebrae to hold everything in place. The screws and rods are not the fusion, the bone is the fusion. The bone is typically obtained in part from the patient, meaning when the nerves are freed and decompressed, oftentimes bone spurs and calcifications and other parts of the vertebrae are removed. The bone that is removed is reused, and it is placed between the vertebrae for the fusion. In addition, some bone may be obtained from the bone bank to utilize for the fusion. The screws and rods are then placed, and they are placed to hold things in place. The fusion takes approximately 6 months to heal together. Once the fusion is healed, technically the screws and rods are no longer required and they could be removed. However, this is rarely, if ever, performed because it would require an additional spine surgery to remove the screws and rods. Typically, patients do not feel the screws and rods, and therefore they are just left in place. One of the risks of the surgery is that the fusion does not heal, or that any of the implants that are placed either fracture or loosen, or there's some complication with the implants placed. In order to make sure there are no problems, when patients are seen in their follow-up appointments, x-rays are typically performed to check for any signs of changes or problems. As long as there are not any problems, then we allow the patient to continue to progress as expected. So again, a risk of the surgery is implant failure or implant breakage or implant loosening. And if that occurs, it would need to be addressed. There is some blood loss during the surgery, but it is not typically significant, and it does not typically require any types of blood transfusions. There is an extremely low risk of blood clot after surgery, but it is much less than even 0.5%. So patients do not require blood thinners following the surgery. We do encourage patients to be as active in terms of light cardiovascular activity as soon as possible following the surgery. They will be notified the day before the surgery by the surgery scheduler regarding the time to show up for the surgery. They will also be instructed on the location. Patients will be seen approximately 7 to 10 days prior to their surgery, and all the instructions will be given to them at that time as well. However, the surgery schedule is not created until the day before the surgery. If the patient is having surgery on a Monday, the patient will be notified on the Friday prior to surgery regarding the time and location. The patients are instructed not to eat or drink anything after midnight the night before surgery, with one exception. If a patient takes a blood pressure medication in the morning, then they can take that blood pressure medicine with a sip of water. But all other medications should not be taken, and the patient should not eat or drink or have anything in their mouth after midnight the night before the surgery. This includes gum and mints and certainly any food or drink. I will see the patient the day of the surgery, prior to the surgery, and at that time we will typically mark the site of the surgery, meaning if the surgery is at the L4-5 level, we will write L4-5 on the patient's back. We do this as a precaution to make sure that we never perform surgery in a spot that was not indicated. At the time of seeing the patient, I will also obtain the information from whoever is with the patient the day of the surgery. So family member, loved one, significant other, friend will obtain the contact information so I can notify that person or persons following the surgery just to let them know how everything went and that the patient is stable. Depending on the extent of the surgery, many patients will be allowed to go home the day of the surgery. Some patients will be admitted to the hospital or even occasionally for an overnight stay at the surgery center, depending on the location of the surgery. If a patient requires additional time in the hospital setting, then that certainly will be allowed. The criteria for patients to be discharged: the first criteria is that the patient's pain needs to be tolerable with medication they can take at home. A prescription for pain medication will be issued for the patient at the preoperative visit, so they will have that medication available. Typically, a muscle relaxant is also a medication that will be prescribed to help with any muscle spasms following surgery. Second criteria for discharge is that they are not having any complications or concerns following their anesthesia. If the patient's heart rate or blood pressure is not stable, or the patient has nausea or vomiting or any reactions to anesthesia, they will not be discharged. The third criteria is that the patient is mobile, meaning the patient needs to be able to get up and out of their bed, they need to walk through the hallway, they need to be able to get on and off the toilet seat, get in and out of the shower, and typically go up and down at least several stairs. If the patients are able to perform those functions even if it is with an assisted device such as a cane or a crutch or a walker, then that is still appropriate criteria to allow the patient to be discharged. So again, pain needs to be controlled. There needs to be no issues following the anesthesia, and the patient needs to be mobile. The surgery again is performed with a general anesthesia. Typically, numbing medicine is also injected to help any postoperative pain symptoms. The patient should avoid any excessive low back bending, twisting, or lifting greater than 10 to 15 pounds. The patients are instructed to begin light cardiovascular exercise the day following the surgery. This typically involves walking. Patients should walk at least 5 minutes 4 times a day, and more if they tolerate. I typically recommend walking before breakfast, before lunch, before dinner, and before bedtime. Patients can walk outside or walk on a treadmill. Patients can also utilize an elliptical trainer or a stationary bicycle. Again, patients should not perform excessive bending, twisting, or heavy lifting more than 10 pounds. Patients do not require a back brace immediately following surgery. At the 2-week follow-up appointment, which is the first postoperative visit, if a patient requires a back brace, it will be issued, but oftentimes it is not required. The postoperative appointment should be scheduled at their preoperative visit. Patients will then be seen at 2 weeks following the surgery, at 3 weeks following the surgery, at 6 weeks following the surgery, at 12 weeks following the surgery, and at 6 months following the surgery. If a patient needs to be seen more frequently for any reason, they will be scheduled accordingly. We always instruct the patients that if they have any questions or problems following the surgery, that they should call the office. They can call the office during business hours, but also after hours as well. If it's nighttime or weekend, the answering service will page me and I will call the patients. We do not want the patients to go to the emergency room without calling us first. If they have any questions, we may be able to address them or see the patient that day. Also, if the patient does require an emergency room or urgent care visit, I will call the emergency room for the patient to alert the emergency room that the patient will be coming. But this is very rarely required. So again, we always tell patients to call the office first. And if we're in the office, we can see the patient. But if not, we can either see the patient the next day or we will make the appropriate arrangements. Hopefully this answers most of the questions that patients have regarding lumbar decompression, instrumentation, and fusion surgery. More details will certainly be given to the patient at their preoperative visit. This present video can be viewed by going to our website at AOSMLV.com. Again, AOSMLV.com. Click on the link of the medical team or medical providers, and then click on Dr. Michael Trainer. And at the bottom, you will see the videos, and you can click on the link for the lumbar decompression, instrumentation, and fusion video. Thank you.